This is that example that I was giving you earlier, where I said that there might be a nutrient-gene interaction, particularly as those women who are either taking HRT or on bioidenticals, or even who are doing birth control pills. In this particular study, they found that there was a significant correlation, a relative risk factor of 1.3, for postmenopausal women consuming a quarter of a grapefruit or more per day compared to controls, whether they were on or not HRT. The net result was that the FDA mandated that on all bioidenticals and all HRT products, there is a warning. Most people don't know this. To limit your intake of grapefruit. As I said, the product, the active ingredient here is called naringenin. It inhibits this particular enzyme called cytochrome P450 3A4. 3A4 is necessary for the conversion of estrone to 16-alpha-hydroxyestrone. And by inhibiting 3A4 with grapefruit in your diet, it actually increases plasma estrogen levels. I don't know if you can see that very well. I'll clean that up for tomorrow. But this is basically a quick and dirty biochemistry chart showing how estradiol gets converted into estrone. 2-hydroxy, 4-hydroxy, and 16-alpha-hydroxyestrones are the metabolic byproducts of this particular pathway. What I've done is put in here the enzymes that are necessary for that conversion. So when you block 3A4 with grapefruit or grapefruit juice, you are actually decreasing the conversion of estrone to 16-alpha-hydroxyestrone, which then increases 4-hydroxy and 2-hydroxyestrone. Increasing your risk, because 4-hydroxy is a very, very toxic metabolite. More toxic than estradiol. And if you look downstream from 4-hydroxy, there is a quinone here called 3,4-estrone quinone, which some research out of the University of Nebraska by Dr. Rogan is showing some significant increases in your risk for prostate or breast cancer or any other types of cancer, because this particular molecule actually interferes with DNA repair. So one of the things that is important, and you'll learn more about this tomorrow in the presentation on how we use this information in a functional practice. So the idea here is that we need to have some initiatives to get people more interested in this topic of genomics, personalized medicine and individualized medicine. I'm doing my job by speaking to you today, and I speak all over the country about this, because I think it's important for clinicians to become aware that this can be a very, very significant piece to your practice. It takes some getting used to. There's a huge learning curve. As I said, I've been doing this for almost 10 years. There's a huge learning curve that's necessary. But part of what the Institute for Individualized Medicine that I put forward is actually trying to do is educate people, educate healthcare professionals, educate the consumer, drive this from the bottom as well as trickle down. And in addition, to get companies who are proactive to actually start doing some of this in-house if they have a self-managed care system. There is some concern that if this goes into an insurance like Aetna, Humana, that they could use this information against you. So I don't see this information becoming quickly absorbed and utilized by national healthcare insurance companies. But if you have a small managed care system, I think it can be very, very valuable. Here are some of the drugs that the FDA is now requiring. If you are thinking of prescribing any of these drugs, including warfarin, you will have to do a particular genetic analysis to see if they can actually utilize this drug in the first place. Individualized medicine was generated, the term was in 1956 by Dr. Williams in his seminal piece called Biochemical Individuality. This is now getting somewhat changed because we now look at epidemiologies, studies which have been in existence for about over many decades. And as I said earlier, many of the epidemiology studies looking at nutrients in particular don't have any relevance anymore because the variation within that population genomically could be so significant that you get no response. Or the other way around. The genetic variation within that population is so tight that you actually get a response. So one report says folic acid does this, another report says folic acid does not do this, and therefore you have conflicting information and patients basically throw up their hands and say, I don't know what to do. Which is where we are. We have to look at individuals. The goal of individual medicine is basically to assess someone's genome, identify what nutrients will speak to that particular genome, and then see over time using biomarkers how that improves that particular person's genomic profile. The qualities that are in individualized medicine, probably many of what you use already, patient-centered, looking at particular genomic profiles, using nutrigenomic and pharmacogenomic information to pass along either to their primary care practitioner or to use in your own treatment or prevention program. The basic premise here is to refine, clarify, and define the diagnosis, to make sure that what you're actually seeing is what's really going on. And if there's something behind the scenes, that's when you start taking proactive action. The scale of economics has shifted tremendously as it relates to genomic testing. In 1999, it took the government $3 billion to sequence the human genome. There are some companies now out there that are doing individual sequencing for $48,000. The costs that I have in my practice, there are 4 panels: cardio, immuno, detox, and osteo. Roughly about $500 a piece. That's my cost. So with this information, you can get a lot of data. If I have a breast cancer patient in my office, it's immunogenomic and and a detox genomic, because every chronic disease has a pro-inflammatory component to it. If you can identify that there's inflammation contributing to that particular disease process, then you can do something about that. The old paradigm is one size fits all. The new paradigm is it's an individualized medicine approach towards treatment and prevention. This was a quote from Personalized Medicine Coalition in 2009, where they're saying that it's going to be a huge shift in how we do medicine in the next 5 to 10 years. You are on the leaning curve of that particular revolution. These are some of the prospects here of putting individualized medicine initiatives into practice through medical schools and trainings like this.